Welcome. Today we're analyzing a serious complication in advanced cancer care, opioid-induced neurotoxicity. Our goal is clear: give you, the healthcare provider, the strategy for quick identification and action. Let's get straight into it. Before we talk management, what exactly are we dealing with here? What is opioid-induced neurotoxicity, and who usually gets it?
Okay, opioid-induced neurotoxicity, or OIN, is a significant clinical state. We're talking about serious central nervous system problems caused by opioid therapy, and it tends to affect elderly, often frail patients, typically those already on chronic high-dose opioids for managing advanced cancer pain. It's a very high-stakes situation.
Right. Now, patients on high-dose opioids are often quite sleepy anyway. So what specific symptoms should really set off alarm bells? How do we tell simple sedation from genuine neurotoxicity?
That's a great point, because the symptoms can be mistaken for the disease getting worse or just general tiredness. That's why being alert is so important. We're looking for a particular set of signs. Sharp cognitive changes, like sudden confusion or delirium. That's primary. But the physical signs are, well, they're really key. Myoclonus, that repeated. Involuntary muscle twitching, that's a classic sign. Also look for worsening sleepiness, real problems paying attention, maybe even visual hallucinations.
So that myoclonus, the twitching, that's the one we really can't miss. Could you give us a sort of high alert scenario, something that should make us act immediately?
Sure. Let's imagine an 85-year-old man. He has metastatic cancer, been pretty stable on his morphine for months. Then suddenly he's not just confused, he's got these involuntary jerky movements, arms and legs. That's the myoclonus. He can't focus, can't tell you where he is, and maybe you find out his opioid dose was just increased for worsening pain, or perhaps he hasn't been drinking much fluid. That whole picture just screams opioid-induced neurotoxicity. You really need to act fast.
That patient example is quite striking, and acting fast is clearly vital. To stop it effectively, though, we need to understand why it happens. What's going on at the root cause? Why does the brain become, well, toxic?
Yeah, this is where we need to think beyond the original drug itself. It's about what the body does with the drug. OIN basically comes down to the buildup of certain neurotoxic opioid metabolites. It's the metabolic waste products causing the problem, not just the opioid itself.
Wait, hang on. So it's the metabolite, not the parent drug. That really changes how we should think about dosing, doesn't it? Especially in vulnerable groups. So which patients struggle most to clear these toxic byproducts?
Elderly patients are definitely the most vulnerable. And it's really for two main reasons. First, their kidney function naturally declines with age. So they're less efficient at getting rid of these metabolites through urine. If the kidneys can't clear them fast enough, they build up. Second, beyond just organ function, older adults often show increased pharmacodynamic sensitivity, meaning their brains react more strongly to the same level of these neurotoxic substances.
Ah, okay. So it's a double hit. Poor clearance and heightened sensitivity. That really puts the elderly at high risk. Besides age, what other clinical factors tend to push patients towards this rapid buildup?
We usually see toxicity when that balance gets thrown off. Key things that precipitate it include, well, obviously, excessive opioid dosing or increasing the dose too quickly. But a really critical factor is acute dehydration. Being dehydrated can worsen any underlying kidney impairment and basically concentrates those nasty metabolites even more. Any patient who already has kidney issues, even mild ones, is sort of sitting closer to that toxic threshold already.
That makes a lot of sense clinically. Okay, let's talk specific drugs. There's often advice about switching opioids if there are kidney problems. Does the actual opioid used matter much for triggering neurotoxicity? Like, is hydromorphone really safer than morphine?
Well, hydromorphone is generally seen as a safer choice than morphine for patients with kidney dysfunction. That's largely because its metabolites are considered less problematic kidney-wise. But, and this is important, we can't just assume it's completely safe. That safety margin isn't absolute.
Can you expand on that a bit? When does hydromorphone become risky?
Even hydromorphone can cause severe toxicity. You see this sometimes with very high total doses. Or, crucially, again, if the patient is significantly dehydrated. The point is that safety is always relative to the patient's baseline function. If they're dehydrated or getting rapidly escalating doses, hydromorphone offers no guarantee against neurotoxicity. Clinicians have to understand that any opioid can potentially trigger this if the toxic load overwhelms the body's ability to clear it.
Okay, understood. So we've got the symptoms, the mechanism metabolite buildup from poor clearance, often pushed by dehydration. Let's switch gears completely to action. What does this mean for managing it right now? Where do providers have to start when they suspect OIN?
The very first step, and you absolutely cannot skip this, is diagnosis. Management must start with a thorough differential diagnosis. Rule out everything else that could cause acute delirium. Could it be sepsis, an electrolyte problem, a new stroke or bleed in the brain? You can't just jump to blaming the opioid until other common, potentially life-threatening causes of altered mental status are reasonably excluded.
Right. You have to rule out the other big scary things first. Once the signs strongly point towards opioid neurotoxicity, what are the immediate goals? What are we trying to achieve right away?
The goals are essentially twofold. Reduce that toxic load and provide essential support to the system. The very first physical thing to do, assuming no major contraindications like severe heart failure, is hydration. Get intravenous fluids going. Dehydration is so often a major driver, and giving fluids aggressively can really help improve how fast the kidneys clear those metabolites.
Okay, hydration helps flush things out. But what about the opioid that's currently causing the problem? How do we manage that toxic load without just stopping their pain relief cold turkey?
This is where a very specific strategy comes in, called opioid rotation. The key move is switching the patient to an opioid that's structurally different. Because the chemical structure is different, the new drug will produce different metabolites. This immediately stops the buildup of the specific toxic substance that was causing the OIN.
But if you switch opioids, isn't there a big risk of sudden severe pain? Or just losing control of their pain altogether? How do you handle that tension, reversing the toxicity while keeping them comfortable?
That really is the core challenge for the clinician, isn't it? When you rotate, you absolutely must use a reduced equianalgesic dose. You calculate what the equivalent dose should be, but then you actually give maybe, say, 50% to 75% of that calculated dose. You're starting fresh, trying to lower the overall neurotoxic pressure. The immediate priority has to shift slightly. It's less about achieving maximum pain relief right now and more about resolving the dangerous neurotoxicity. Pain can be managed more conservatively during this stabilization phase, knowing the altered mental state is the biggest immediate threat.
What about the dose of the original opioid, the one causing the trouble? Since the issue is buildup, does just reducing the dose help, even if they're still in pain? That seems a bit counterintuitive.
You do need to carefully reduce the dose of the ascending opioid, yes. The clinician is constantly balancing resolving the neurotoxicity with providing enough pain relief. Often, the patient's perceived pain level is actually amplified by the delirium and confusion itself. As the neurotoxicity starts to clear up, their agitation and discomfort might lessen naturally. This allows for a more cautious, slower titration upwards of the new rotated opioid once they're more stable.
This whole process sounds like it needs really close watching. When does this situation become too much for outpatient or home care? When is hospital admission the right call?
Admission to the hospital is definitely needed for close monitoring in any severe or rapidly worsening case. If the patient seems like they're getting close to having seizures, for example, or if their mental status is just plummeting despite initial hydration, they absolutely need to be admitted. Being inpatient allows for minute-by-minute observation if needed, titration adjustments perhaps hourly, and making sure all the supportive care is continuously maintained. So thinking about all these points, what's the single most important message? What's the main clinical takeaway for patient safety when it comes to OIN?
I think the primary takeaway has to be extreme vigilance, especially being alert to subtle changes in mental status. You always need to monitor patients on chronic opioids for any new confusion, any sign of that muscle twitching, the myoclonus, or any sudden shift in alertness. And this alertness needs to be heightened, really heightened, in patients who are elderly, frail, or known to have kidney problems.
But the key opportunity is that it is reversible. Recognizing it early and intervening aggressively, and specifically, particularly dealing with dehydration and doing that careful opioid rotation, that's what prevents it from escalating to really life-threatening things like seizures.
So early recognition and having a structured plan for intervention dramatically improve outcomes for these patients on long-term opioids for cancer pain. The vital part is understanding that the metabolite, not just the original drug, is what you need to manage.